Hi everyone and welcome to today's webinar. We really appreciate having you take the time out of your day to join us. We've got some very good speakers today and hopefully have a very interesting session for you all in exploring how technology can assist in infection prevention and control practices, including training. Today's session will run for approximately 45 minutes long with a Q&A session at the end. If you can't stay for the full session, that's absolutely fine. So you can feel free to send any questions through to us at hello@bluemirror.ai and we'll make sure that we follow up with you. All attendees will be muted for the session, but if you have any trouble hearing us, we suggest that you exit and rejoin the session. We will monitor the live chat here, so if you have any questions, you can pop them in there and we'll respond to you either throughout the session or at the end during the Q&A session. If we don't answer your question today, we will touch base with you afterwards. And finally, a copy of this webinar will be made available in the coming days on our website at www.bluemirror.ai. Today, we want to explore the theme of using technology in infection prevention and control, with a focus on training and auditing. We know this is an area in healthcare that's under immense pressure across the world, and improving practices and competencies among staff is a very high priority. However, we need to consider the challenges that are faced in infection prevention and control, and how technology can be a conduit for IPC teaching, assessment, and auditing. So today I'll introduce our guest speakers and we'll get straight into why PPE training is so important, common challenges in IPC training and auditing, a focus on the Manawa Simulation Centre, exploring whether or not the training that we deliver is effective, and then transitioning from paper-based to digital solutions. And finally, after that, we'll open the floor to a discussion. So who are we today? Joining us, we've got Ruth Barrett, an IPC expert and independent consultant, Chris Beasley from the Manawa Simulation Centre, and Mark Cox, a health IT consultant from MEG. And finally, kia ora, my name's Holly Hodson. I'm the head of sales for Blue Mirror, and I'll facilitate today's session. So I have a background in nursing, and I'm a fierce advocate for nurses and anything technology that can streamline and create efficiencies for us and reduce our workload. So let's get started. So we'll begin this session today with Ruth. Ruth is a registered nurse and is credentialed at expert level in infection prevention and control through the Australasian College for Infection Control Professionals, and she holds a Master's of Advanced Practice Infection Control and Prevention from Griffiths University. She has more than 25 years experience in both the public and private sectors here in New Zealand and Australia. So Ruth, I will hand over to you. Or you might just need to unmute yourself there, Ruth. Yep, there you are.
There I am, yep.
And if you want, you can turn it on if you like, Ruth, it's up to
you. Okay. Okay, so good morning, everyone, and thank you for joining, and it's a pleasure to be here to talk to you today. So the focus of my short talk is really just to sell PPE training to you and just reinforce why it is so important and why we should be repeating it regularly as well. Next slide, please. So there are a number of reasons and avenues why we should be doing training with personal protective equipment. I mean, first and foremost, we need to know how to use it and also how to correctly use it. We need to train so that we're familiar with what PPE products are out there at the time. And using PPE correctly, that can contribute to an overall culture of safety in your workforce. Of course, there are legislation and there's standards that we need to comply with, and that's from an organisational perspective. And regular and up-to-date PPE training will always provide some preparation at least for future infectious outbreaks. Next slide, please. Just want to start off with just referring you back to a little bit of research I did myself for my PhD. It was a very small part of the PhD, but we did look at PPE training programs in Australasia, and we had a look pre-COVID. So this was pre-COVID, and it was during the years 2019 to 2020. And we basically, it was an online survey sent out through the various infection prevention control colleges in New Zealand and Australia. Next slide, please. And what we were looking to see is what did they actually do around PPE training and what was incorporated in their training programs, etc. And in a nutshell, nearly every hospital has an orientation program for new staff, and nearly all of them included some sort of PPE training, whether that was it directed people to an online module or they did it in person in a classroom setting or otherwise, but there was some sort of PPE training at induction for new staff. And this survey was really only sent out to the sort of larger hospitals. So it didn't include any small private surgical facilities or aged care, anything like that. So these findings really reflect a larger hospital population. Only less than half of them, however, provided any annual updates in PPE training, and less than a third of them did not actually have any practical component. And as we've learned with COVID, practice is so important when it comes to correctly using PPE. And interestingly, at that time, only half of the people that responded actually included masks in their training. And maybe there was the general assumption that we had that, you know, there isn't really much to teach with masks. Of course, nowadays we now using respirators a lot more as well, and that there's a lot more training involved with them. And additionally, after they've done the training, there was very few people actually monitored whether PPE was used correctly or not. Next slide, please. So what are the implications for not doing PPE training or not keeping up with it? Well, you know, obviously people will not know how to use PPE. Their skills in using PPE will be poor. Their knowledge of why they're using PPE, that's very important, that people understand why they're using a certain type of personal protective equipment or a specific piece of personal protective equipment. So for example, why are we putting a mask on if there's something that's only spread through hands? A lack of training also results in a lack of experience and expertise when it comes to actually using it, as I just said. And it does reflect that way we have of just having a just-in-time approach when anything nasty sort of pops up, like a firefighting approach to PPE training. If we do have poor PPE skills, then we end up with unsafe donning and doffing, and that obviously can contribute to cross-infection and transmission of infection. Next, please. What we did notice in COVID, of course, that PPE was used extensively. I mean, COVID just raised the bar when it came to the amount of PPE being used, and all sorts of PPE was being used. But nearly everybody requested or required training. So it seemed to be that hardly anybody had any retention of knowledge around the use of PPE, even basic stuff like gowns and gloves and medical masks. Now, this had a massive resource implication for the infection prevention control teams and the other educators and trainers who were pulled in to do this sort of training. What we did find, of course, was that PPE was worn incorrectly, it was taken off incorrectly, and because of the shortage of PPE items and because of people's underlying fear of COVID, especially in the early days, lots of various items were brought in to try and protect people, and these came with their own cross-infection risks. So this is a picture of someone wearing an underwater snorkel instead of an N95 mask. And there has been quite a bit of research looking at PPE use during COVID, and many of them have found that even with all the training that went on, there was still quite a lot of errors, especially when it came to taking off PPE, which meant that staff were self-contaminating themselves. Next slide, please. So one of the reasons another reason for keeping up your training is actually keeping up with those products that are out there. The product market is fickle in this day and age, and you know, one day you've got certain type of gowns, and the next day a different type of gown comes in, and the same with masks and particularly respirators. So if you're regularly doing PPE training or you're updating annually, at least you're familiar with what's in stock in your facility at that time. If you are in an infection prevention control position or role, get involved with what's chosen for your PPE choice, so that you know that it adheres to standards for PPE and that it will be usable, that people in your facility will actually want to use it. And don't forget about your temporary or agency staff. They may not be familiar with the types of PPE that you have in stock. Next slide, please. So the other thing that I mentioned was that if there is a lot of PPE training going on, or if you do annual updates, which you should, that all contributes to your organization showing that it cares about their staff. It has a safety culture, a culture of looking after the occupational health and safety of staff. And the more that's done, the more people will permeate that culture. And it means that you can help keep your staff safe from the effects of not having PPE or using PPE incorrectly. And then if an individual is well versed and has experience and skills, that can influence other colleagues and people in the workplace. And it all contributes to an overall culture of safety in the workplace. Next slide. Now, finally, I'm just going to touch on things legal and standards, and I've just put a couple of slides in that relate to Australia and New Zealand, and I apologise for anyone listening from any other countries, but I've just pulled out the two main countries in our hemisphere. So in legislation, it's all around health and safety legislation. So it's similar in Australia and New Zealand, but this is from the Work Health and Safety Regulations for New South Wales, which is one of the states in Australia, and it's similar across all the states in Australia. But basically, anyone who has a business, conducts a business, has to provide their workers with information, training, and instruction in the proper use of PPE, as well as providing the PPE. They're responsible for training and instruction. Next slide. In Australia, we have standards. So these are the best practice standards. And in Australia, it's the Australian Commission on Safety and Quality in Healthcare that has its standards. And in particular, we have the Preventing and Controlling Infectious Standard in our quality safety standards. And standard 3.07 states that this organization has processes for the use, training, testing, and fitting of PPE. Next slide. As I said, in New Zealand, our legislation is very similar. The PCBU is the premises or the operating facility organisation. So it has to provide the worker with information about training and instruction in the proper use of PPE, and that's legally required. Next slide. And our standards, so in New Zealand, we have an overall standard for healthcare facilities, which is called NAB PIWERA Health and Disability Services Standard. And within that, there are 3 areas where you could refer back to that would suggest that you need to do regular or at least do some PPE training. And so that's about making sure that people who work within your facility have the skills for the services being delivered. Now, if they're going to need to wear PPE, they need the skills to be able to wear that, and they need the knowledge to be able to use it correctly. And they also, 2.4.4, they need to receive an orientation and induction program that covers the essential components of their service, which would include the use of PPE. Next slide, please. So just to summarize why PPE training is important, well, it is important. It's also required and necessary. It should always really incorporate a practical component, and it should be repeated at least annually. Thank you.
Thank you, Ruth. It's fascinating, and I think to your point, even for myself, working as a registered nurse, I did some work through COVID in the MIQ and hadn't practiced PPE donning and doffing at all since I began my nursing career. And it was fantastic watching a room full of nurses think, gosh, I've got absolutely no idea how to do this properly now that we're being asked to show how we do this and do it safely. It was quite fascinating, really. Prior to that, I would have told you I was very confident in PPE donning and doffing. So we know training is an essential part of implementing an effective IPC measure, whatever it is. Training is really important to improve those outcomes. Here at Blue Mirror, we've spoken to a lot of organisations over the years exploring what their challenges are in IPC training. And it's quite fascinating because no matter how big or small these organisations are, the challenges are quite similar across the board. So when we focus on training to implement effective IPC practices, these are the common themes that we see. And technology really needs to support reducing these barriers. So first of all, healthcare acquired infections are a major threat. So, I mean, most people on this call are probably aware of that. The World Health Organization note in particular that antimicrobial resistance and the spread of that is now classified as a top 10 threat to humanity. Resourcing is something that has definitely worsened since COVID. Entering a pandemic with an already strained workforce has had a massive impact, and organisations across the world are really struggling to get back to that adequate staffing level. Geographical barriers. This is an issue that faces many, and particularly in the likes of Australia. Delivering training to everyone in your organisation sounds very straightforward, but for some organisations, the level of travel required to do that is huge. Connectivity is a funny one in 2023. It seems no matter where the hospital is situated, whether you're a rural hospital in the middle of nowhere or you're in a central city somewhere, there's almost always a report of poor internet connection somewhere in your facility. And again, that can really impact how you adopt digital tools in your organisation. Coordinating training seems simple, but anyone that's responsible in coordinating training knows that it's a complete minefield. There is a constant tension between having clinical staff available on the floor and being available for training. And when there are low staffing levels or an increase of workload, training is always impacted. And the last point here is staff turnover, and that connects with what you were saying, Ruth, in your talk. If you've got high turnover of staff or you've got a lot of casual staff in your organisation, no matter how much you plan and coordinate training for a group, whether it's at regular or set intervals or not, the reality is with high staff turnover, that investment can at times seem futile. So that's a real challenge for organisations. So collectively, we need technology that creates efficiencies, eases the pressure on those task-oriented activities, and frees up that clinical time for people with those clinical skills to be put to better use in practice. And before I hand over to Chris, just the last slide I want to share. What does an IPC lead, manager, educator, or champion do? So we're really not talking about a person that has a set structure of tasks to complete each day, focusing solely on IPC. We're usually talking about people who wear many hats, responsible for a lot, and constantly managing tension between competing priorities. So again, we need to work smarter, not harder. And technology can be that conduit for better learning, improved confidence, and competence in clinical skills. So this feeds very nicely through to my next introduction. Chris joins us as the Nursing Simulation Lead for Waitaha Canterbury, based in the Manawa Simulation Centre. She's a registered nurse with a clinical master's, achieving graduation in advanced simulation-based learning from the Centre for Medical Simulation in Boston. In addition to this, she's an adjunct lecturer at the University of Canterbury and has a special interest in simulation debrief and clinical hot debriefing, supporting staff wellbeing. Chris, you're a very busy woman. I'll just quickly talk about Manawa. So the Manawa campus in Ōtautahi, Christchurch here in New Zealand is a purpose-built facility that has several high-tech simulation rooms to provide real-life experiences to students and staff. The facility is shared by the University of Canterbury, Te Whatu Ora, and the Ara Institute of Canterbury. So Chris, I will now hand over to you to tell us a bit more about the exciting stuff you guys have been working on. and you might just
Thank you, Holly, and thank you, Ron, for inviting me to talk today. Can I just say, and thank you, Ruth, for sharing your qualifications with me as well. I'm not an infection prevention and quality advisor, but I do appreciate it. It's great. So today I'm just talking about our involvement in the PPE training and how we supported the COVID response here in Canterbury. Canterbury was one of the first places that contracted COVID within some of our health centres, and unfortunately it was within the residential care setting, and also unfortunately within a dementia care setting. So we're going to talk a little bit about that and some of the other projects that we've been involved with with PPE training. Thank you, Holly. Next slide. So Manawa, as said, was a dedicated health education facility with a state-of-the-art simulation centre in the Health of the Health precinct. So what we've done is we've collaborated with University of Canterbury and Aura Institute, which is part of Pakenga, and we all the health sciences are in one building. So we actually have student nurses, midwives, radiography, research medical students, psychology students, and registered staff from the main hospital site, all training in the same environment, which is quite unprecedented in many places. The reason this works really well in cases of things like PPE is that we can actually start the training very early in somebody's career, and in fact our training starts in the student education rather than waiting for them to come to become employed by the CDHB. Thank you, Holly. So Manual Simulation Centre is 100 square metres of simulation rooms designed for both student training and post-registration training of any healthcare worker, plus non-registered workers as well. We have a 9-bedded ward area where we can do simulation and where we can do clinical skills, etc. And we also have a theatre, an ED emergency room, and a few classrooms and VR as well, and it's shared with so the bottom picture is physiotherapists doing an ICU airway course, and then above that are students doing injection training, and then the control room view of the ward area looking out into what we can see in there. So we can do real life simulations or we can do clinical skills. We've been opened about 5 years, and we are open to, we do have the mind that we help anybody with training within healthcare, because at the end of the day that helps us in the public system. So we have people from the Defence Force that come and train here, their medical squads. We have the air ambulance personnel, we have St John's and some of the private hospitals as well, because, and some of the residential care homes as well, because we think if we can train people to do some practices well in their care settings, then that means that it doesn't have the impact on our public sector and lots of people coming through ED and things like that. So we have lots of connection with the outer healthcare service as well. Thank you, Holly. So as I said, when we first improving IPC practice with training, when COVID started, unfortunately, we went into lockdown in New Zealand, and unfortunately that meant that all training was cancelled, and I wanted a way to still be involved, to be able to do some training, but also to be able to support the work that was being done in the residential care homes and around the hospital environments. We have 17 different sites that are part of the health service, plus all the residential care settings, etc., and primary care. So one of the things that we helped do was the bottom right picture is what we call our PPE stands. So the bottom's got the aprons that are yellow, and then there's a platform for your alcohol wipes, your scrub, some information and goggles, all the gloves, and finishing with the masks at the top. The reason that this was, we helped with biomedical engineering to design this, because we found that in hospitals and in residential care, there seemed to be just 1 point for both donning and doffing. And we quickly realised that that wasn't best practice, and we needed to separate both areas, and we needed to keep clean equipment away from where we were taking equipment off. And so, and everybody had something different, how they set it up, and also the structure. So there'd be big tables, there'd be big trolleys, lots of disorganisation as well, things just scattered around. And so this keeps it nice and tidy, and it means it's on wheels and we can wheel it wherever we need it, and it keeps all the clean equipment together, and it's easy to use, and you can get everything that you need. And we found that they've worked extremely well within Canterbury, and in fact they were mass produced at one point, so that every area has got them, and they have been, and we train with these as well, so that people get used to seeing them and they know what they are. We then was approached by Romy many moons ago now to have a look at the Blue Mirror app for donning and doffing, and we found that once we started the training, our idea was to train people who had never done donning and doffing before. And this is a picture of biomedical engineers who you wouldn't think needed to know about donning and doffing. However, they go into clinical environments to maintain and troubleshoot mechanicals, mechanics, etc. And so really they were, these people and other people that we don't class as needing PPE training, like our cleaners, our catering staff, etc., were unseen populations that we needed to do some training with. And we were trying to see how easy the app was to use with people that didn't have any knowledge of PPE at all, and it seemed to work really well in a training environment. We did a lot of work on hand washing, and we have a really big scrub bay, and that's one of the things that we put into orientation training as well around hand washing. We were finding, as we were seeing people donning and doffing, actually hand hygiene on the doffing was very poor, and so we really needed to put a lot of extra work into that area. And then we were involved as well. We became one of the sites where we were fitting N95 masks for staff. So there was an appointment system, and they would come over and get fitted for their mask so that they knew which size and mask they needed. And we've continued that with all our nursing and midwifery students. And in their third year, they all get fitted for their N95 mask before they go out into clinical placement and then become registered within their profession. So that work is done before they become an employee of our system. So that helps a lot, because it does cut down on the number of people that we have to fit each year. Thank you, Holly. One of the projects that I suggested we could do in light of our first outbreak of COVID being within a dementia care facility in the community, and we realised very quickly that PPE was a major problem. For example, the type of PPE that people had got, I'm not sure about how residential care works in other places, but here resources are scarce as well, and they're limited, and so we would find that people were reusing stock as well, especially gloves. And so my project was to establish an IPC resource staff on PPE, and they became the PPE champions. Now, these were 15 dental technicians that we did a full day's training on PPE, how to put it on, how to take it off. They simulated it many times and checked each other, and we went through it thoroughly about where the areas of concern might be and why it was an area of concern. We also had two we had 2 ARC facilities that had got COVID, both had dementia patients. And what we did was we started on the 20th of September, finished on March the 21st. We had a lead through the Infection Prevention Control Service, Mike O'Canahan, and our project team that looked at some stuff. And what we did was we sent a PPE champion out on every shift to both of these units, and their job was there to maintain the safety of the staff. And when we explained it that way, they were very well welcomed, and they would observe people putting PPE on and taking PPE off and stopping them from making mistakes and errors that would cause cross-infection. And we marketed it as a support that when you're busy and when you're stressed, this is just another pair of eyes to keep the staff safe and stop that cross-infection and stop the spread, and also from people taking it home as well. We identified effective donning and doffing procedures, and we also had to do a lot of work around the unique environment of dementia care. Some of it was quite surprising to some of our staff, and also some of the behaviours that they saw, etc., were a little bit yeah, a bit anxious for some people. And also understanding how human factors affected people's behaviour. So when people were rushed, they didn't take as much care to take off their PPE, or they would go and answer a telephone still with their gloves on because it was an urgent call, etc. So we really did have to do a lot around human behaviour. And then once that project had finished, it was IPC thought it was a great project, and so we did the similar project in September and March in the ED service, and we've set up PPE champions there as well, and that's really gone great in that you know, when we have a trauma, there is somebody who might be COVID positive or was COVID positive, we would have a PPE champion looking at what type of equipment they needed essentially in the room and what didn't need to be in the room, checking all the people, external partners coming down to ED to look after the patient, making sure that they were donning and doffing correctly, and just really making sure that everything was as it should be. And that worked, that is still ongoing, and we're hoping to roll out PPE champions throughout the hospital through infection prevention and control. The other interesting job we did was we made PPE champions of the military, because at the time of COVID we had an international cricket team come over, and they were in quarantine, and they went to a sports centre where they could practice, but they had the military around them, and we had to show them how to pick up a ball, a cricket ball that was potentially infected, and keep themselves safe, which was quite ingenious and quite different, to be honest. Next slide, please. So that's about the work that we've done in PPE. We do obviously a lot of work, but we've worked quite closely with IPC on how we can get this training more formalised, probably into clinical, and how it can be used more effectively. We are starting to we have put PPE training in all our clinical orientation, but that only means that we touch base with the nurses and health staff within nursing. We don't actually get to see anybody else. And so I think we've still got a bit of work to do in making sure that we touch base with everybody within the health service to make sure that they're protected and that they're protecting others. Thank you, Holly.
Thanks, Chris. That was fantastic. Manawa Simulation Centre is amazing, and it's such a good example of collaboration because, like Chris said, the training that's offered, it goes beyond a training facility for hospital staff, and it's for everyone. And I think that inclusivity is really important, especially in the likes of aged residential care, where, you know, a lot of non-health staff have more contact with patients than the health staff in some cases. And it's great from a nursing perspective that students are taught correctly through simulation how to don and doff prior to starting their roles, because a lot of organisations we speak to don't the students don't have that training, it's expected that that training is delivered when they begin their journey of their whatever their role is in hospitals, and often hospitals don't offer that training as soon as they start. So there is a big gap there, and simulation-based training is very fun, so it's far more exciting, I think so. So moving on, how do we know if our training programs are effective? And this is a key thing. If we look at PPE training as an example, most training programs follow a similar structure as what you see here. So the staff member receives some form of orientation training, and in a lot of cases this is one-on-one or in a group face-to-face with an IP educator. Then the protocol changes or is updated, or the PPE might change, and this change is communicated by an internal sharing of slides. Sometimes a video or posters on the wall are updated. After a period of time, and this was evident in gearing up for COVID, is that staff didn't feel confident in PPE donning and doffing, and then all of a sudden there was a huge demand for PPE refresher training and not enough educators to do that training. And that's certainly something that we've spoken to many IP educators about. So here from Blue Mirror, we've spent a lot of time engaging with experts in IPC and education from organisations all over the world, and really focus on where the issue lies. And what we know is that it is a process problem. We've got guidelines, we print the posters, share slides and videos, implement, train the trainer, but what happens after that, we've coined it the black box of hope. So we progress through that process, but then we lose visibility and tend to only re-engage when things go wrong and our attention is required retrospectively. So because of this, there's a big shift from manually intensive activities to adopting digital solutions that can help streamline this process for us, which feeds on through to our next speaker. So our final speaker, Mark Cox, will talk more about what he does in detail. So let me pop Mark's face on the screen. There you are. Mark is a very seasoned executive who's worked internationally in the health technology industry for many years. He's a wealth of technical and clinical knowledge and is passionate about improving the health and wellbeing of communities through developing and using advanced technology. Mark works with MEG, a company that has a strong focus on digital quality management systems for healthcare, and more specifically, improving care quality and patient safety. So Mark, I will hand over to you now.
Hi there. Yeah, my name is Mark Cox. Been involved in health IT for 35 odd years now. Excited to be involved in this seminar, and excited after 10 years or so being in IT and infection prevention control to be discussing about, you know, how do we improve, how do we use technology to make your lives easy. Next slide. So, are we delivering on our promise to provide great care for each patient? It's a good question, and the regulators want to know. Next slide. So, but to do that, what they want is for you guys to do a lot more work, collect a lot of data, write up reports, which may largely be ignored. So involves a significant amount of work for you if none of that is automated. Next slide. And of course, that takes you away from the good things that you do involved in patient care. Next slide. And then you want to put up these standards, and are you getting good value for the time that you spend doing some of these audits and all these quality procedures, is the accuracy enough? Is the data accurate enough to get the information that you need to make your decisions? Next slide. So auditing is a really good example of this as a process where regulators are trying to bring in wanting you to collect a whole lot more information, but it's using up a lot more of your time. And is there a lot of value in the audits and some of the processes that you are going to do? Next slide. So this is a classic slide that relates to a lot of people around the auditing process, and a lot of you, I'm sure, can understand what's going on here with Excel, with Access databases, with emails, with paper, with Dropbox, all sorts of things that everybody does to do their auditing process and get around the problem of with data and data collection and presentation. Next slide. So just outlining those problems, we have a problem at collection, that it's often on a clipboard or directly into an Excel file. Using photos for evidence may be a new step, but it's actually really, really manual, and it's on your phone and you have to copy it. And if we want to follow up an issue, we have to write that on a piece of paper, and then when we get back to the office, we'll send an email, and we probably won't follow that up. Excel seems to be the tool of choice for a lot of people, which is all fine and dandy, but has a whole lot of problems, and it's probably a solution from 20 years ago, not for 2023. We have a problem with dashboards, so the Excel data is perhaps stored locally on your database, on your PC, or on a file server. How do your management easily get access to that? And one of the things we need to look at in 2023 is around data and consistency, and where that data is stored. Is it stored in a reliable form? If a person leaves an organisation, can people get access to that data? And also a commonly ignored problem is around photos and whether they're held on personal devices, which get added to your personal photo collection at home of patients. Next slide. So what's a technology move that's helping and making a revolution here? And there's really three things that I've summarized. One is mobile, and using mobile properly, so we get away from this clipboard mentality. Cloud allows you to, you don't have to install and go to your IT department and get a PC or a server and load software on it and involve IT in a big way. So cloud allows you to sign up, get something installed really quickly, and get it up and going really quickly. And the other option here is the move towards international software companies. So Romy and Bluemurra are selling all around the world. The company that I'm involved with, MEG, are based in Ireland and are selling all around the world. Location is not a problem, and it's helpful that we have cloud-based systems with international staff based all around the world who can help and support people get them up on these pieces of software at a really good price point. Next slide. So with MEG, what are we trying to do, and how does it relate back to the slide that I just had around cloud and mobile? So MEG uses a mobile device to do your data collection. It uses a cloud-based reporting system so that you can set up all your dashboards and report them in management really easy. And it has a system around closing the loop, so that if you find a problem, if you find an issue, then you're not just emailing and hope that it'll get solved. You follow that up. Next slide. So mobile, really, really important. It's got to be user-friendly, easy to use, and also allow you to get up and running quickly. And one of the nice things with this international playground is that you can find out what other people are doing around the world. And with MEG, there is an extensive library of audits available. Next slide. So this is an example of some of the audits you could have in MEG across the whole platform. Next slide. And then within IP&C, there are a whole lot of other audits that you can use. So examples here about Australian standards, ASIPSE standards, ATSIC standards, New Zealand standards, and you know, what you want to be able to do is when you get this cloud-based new piece of software is get it up and running fast. So if you'd see, you know, an audit that someone else has done, we can get that loaded up and get you started quickly. Next slide. So I touched on closing the loop, and this is a really important part which often gets missed in the audit process. So perhaps you're doing an audit, you're doing a cleaning audit, you see there's a problem with soap dispenser. You perhaps at the moment might write that on a piece of paper, take it back to your office and email them. So with the new type of technology out there, you can record that, you can take a photo of it, you can create an action item, you can assign it to maintenance. When maintenance fits the problem, they can take a photo to prove that they've fixed the problem, and that issue gets closed. It's reported against statistics so that we can see how long it takes soap dispensers to get fixed across your organization, and that gets extended out into any type of action item and follow up that you have to do. Next slide. So the statistics from this sort of thing get put into a cloud-based service. So anybody within your organization can see how your department, how a ward, how your hospital is comparing against each another ward, how your maintenance is comparing against another ward, how your cleaning services are compared. And it's all in a service. So even if the staff leave, that platform has been set up so that the next person can come along and continue on that standards, and you can compare the audits that you did last year with the audits that you're doing this year and compare it against international benchmarking. Next slide. So Meg has done some case studies on auditing, and what better place to do it than Guys and Tommy's in London. And these are available on the website, but a good example of what can be achieved. Next slide. So 50% reduction in audit time. So that's mainly around using of those mobile devices, a technology change that's enabled you to come in and be more efficient. And because the reporting is all automatic, there's a huge improvement in the amount of time it takes you to do your audit reports and sending it off and getting that sent off. And if you then want to upscale this whole process, then you can do that quite easily. It's not like you have to go to your IT department to get some more equipment and more software and that sort of thing. Next slide. So the future, what's the future? Well, we need to move on from paper to get to where we are now. Next slide. But what we want to do is move from a reactive type of environment where you're just doing compliance, you're doing your audits to make sure that you meet your numbers, to a proactive sort of environment so that you have a suite of audits, you plan for those audits, you have a schedule, you use your cloud-based software to schedule those audits throughout the year. You get a number of years of history and a number of years of data in your database. And where a company like Meg and also Blue Mirror are moving is around looking at predictive and using AI to build on that data that you collect. So moving from paper to Excel to a database of information around your audits and your activity within your hospital to be able to go, oh, I think might be a problem, in this sort of situation where we're going here, this hospital, this ward, these people, this situation. So that's the next step that's going to come along, and the Meg R&D team are working on that, particularly with the customers that have been collecting this data over a long period of time and have a useful database of information. And I think that's about it for me. Thank you for your time. Oh, if anybody wants a free trial, if anybody wants to know what audits are being done around the world, we've got around 260, 280 audits that we've implemented in the system. Happy to have a chat around, if you want an audit, we can show you what other people are doing, and that's my email there, mark@meggitt.com. Thank you.
Mark, and you're absolutely right. Technology needs to be friendly and simplistic in its design. I think that's a real key takeout for me from your presentation. And also, to your point on data transparency, it allows, if you have full transparency over your data as an organisation, you can have a targeted approach to where issues are and how you tackle that, rather than having a lot of manual, very resource intensive lists and jobs for people to do to gather that information. Moving forward, before we conclude today's session, I'd like to just take a couple of minutes to show you a quick video about Bluemirror for those that haven't seen us before, and how we address those barriers that we've talked about today, specifically within PPE donning and doffing for this one. So this video is very short, it's only 2 minutes. I'll play it now.
Meet Barb. Barb is the infection prevention and control lead for her organisation. She is passionate about reducing the transmission of infections with proper PPE use. Barb knows training can be time and resource intensive, but is so important. Sometimes Barb uses a train-the-trainer approach, which helps give some of her time back, but means she isn't 100% confident in the training that is being delivered to the end user. Barb must work with what she has, and some compromises must be made. For people being trained, it can be confusing, and remembering the sequence of events can be difficult. Barb has to work around multiple challenges. How does this impact organizations? Barb knows that compromising the training affects the overall outcome. That is how Barb learned about Bluemirror, a technology that can help her scale PPE training. Bluemirror is a virtual PPE instructor on a tablet. Bluemirror provides an extendable resource for your IPC training team, providing one-on-one practical PPE training. Training is delivered in a consistent, standardized way, giving real-time feedback every time an error is detected. Expand your PPE training program. Train everyone, any day, anytime. With Bluemirror, Barb has the ability to track and manage her PPE training, giving quality one-on-one training to all staff without the need to deliver it herself. Here is what some of our customers are saying.
It saves each instructor half a day.
It's easy and efficient for teaching a large group.
Bluemirror was super easy to implement.
We are Bluemirror, making PPE training work for you.
I'll just move to the next slides. So that brings our presentation to a conclusion today. Firstly, I'd really like to thank our speakers, Ruth, Mark, and Chris. Thank you very much. It was a really good session. I'd like to open the floor to any questions or comments that people have. If you, on the screen here, it says chat. Actually, it's under the questions section for the attendees. I don't think you will be able to use the chat feature, but if you open the questions box, you can type your question in there. If we don't answer your question today, we will follow up with you, so don't worry about that. And remember, a copy of the webinar will be available later this week on our website. So I'll just turn my camera on. Chris, we have a question for you. Do you find it's difficult for people to release their staff for training, or do you think, I guess, from the simulation side, is there a little bit more buy-in from management to allow their staff to have this training?
So obviously since COVID, there's a lot more buy-in for people to have the training. Obviously, we still have our work personnel deficits here. So we're very much of the, I'm very much of the idea that if staff can't get to us, then we go to staff. And there's no reason with our little trolleys and things that we can't, all right, we're not going to hit as many, but, you know, we hit, if we go around one floor and hit three or four wards, you know, we're at least catching some people. So yeah, we'll go out and do the training rather than them coming to us.
Fantastic. That's such a good, that's fantastic. Mark, we have a question for you. How do you find, or do you have objections for rolling out new technology in organisations? Because I know for some people you can get a bit fatigued from that, and depending on who you are in the organisation, I guess it does take a bit of a toll from an organisational standpoint. How do you guys approach that?
It depends on the culture of the organisation, but what you find with some of the new tools and perhaps products like Blue Mirror and Meg is that they're self-contained and really user-friendly to use. So the users embrace the technology quite fast, and that's really a good indication of some of products that you should be using. If it can be adopted really fast and really easy, just go and do it and not get involved in a lot of the processes around that. And a lot of these cloud-based products are priced so that you can give it a go and give it a try and then upscale it without too much of an influence and not getting the IT department involved too much at the beginning.
Yeah, we definitely find that as well. I think for us, any objections, our answer is just have a try, see what you think. There's no over explanation of how to use it. There's no user manual or heavy instruction sheet. It's just have a go, see if it works for you. And for us, 9 times out of 10, people are really impressed because it's very easy and simple, and that's what it should be. Absolutely. There's a question for me. So the question is, does Blue Mirror replace the need for anyone to be educated on PPE training? And that's a really good question, and we do get asked this, often not by a nurse. The key thing for us to highlight is that for PPE donning and doffing training, there's 2 components to it. One is the clinical context behind it, why you choose the PPE you choose, what scenario you have in front of you, and what's the right way to approach that. Like Ruth mentioned earlier, do I need to have a mask on right now, or is it just gloves? That's important. Then the other side to that is the practical component, and that's the bit that we come in as an extendable tool essentially for the team to say, practice as much as you can and practice as much as you want, because any training, you will train a room full of people and everybody learns at a different pace. So for us, you have someone that does 1 session, they're super confident and they're happy as. Other organisations or other people, they want to try it 4 or 5 times before they have that confidence level, and it's important to facilitate that and give people time and space to really digest that training. But and like what Chris has spoken to today, the simulation-based training is so important to digest that and also apply that knowledge in a real life scenario, and that's what we offer. So we always talk to nurses in particular about being an extendable resource for your training team rather than a replacement. So hopefully that answered the question. Can
I just come in there, Holly?
Certainly.
Yeah, so I totally agree with you. I think freeing up time to do the practical component of, training and retraining or, practicing, anything that frees up infection prevention control specialist time to focus on other stuff is definitely a bonus. And remember, the infection prevention control knowledge around why you're wearing stuff and in what scenarios, that comes into our work anyway when we're doing ward rounds and etc. But the actual skills, I think, embracing technology has got to be the way to go to just streamline everything. And the same with like auditing, whatever. If we can sort of make that easier, then there's more time for, I would say more critical stuff. Yeah,
absolutely. We've had another question. It's specific to Blue Mirror, but it's not really. Would Blue Mirror tool be effective in general practice setting? And I guess there's 2 components to that answer, and I can see Ruth's definitely got an answer to this question. You can go first, Ruth.
Yeah, I'm familiar with the Blue product, and I'm also familiar with general practice, and definitely it is applicable to general practice. General practice, as I said when I talked about my research and my experience working with PPE is that general practice was one of those areas that really didn't use PPE very much at all, and yet they were the frontline people, the frontline healthcare facilities when, along with ED, when COVID hit. And so doctors, GPs, practice nurses, it was a big step up, and they had to do a lot of training, and there was quite a lot of concern around their skills. There's nothing in Blue River that wouldn't apply to a GP practice, and absolutely it would apply, and it would be a great way to keep those skills up and go into the new normal, as it were, and think about some of those, using those pieces of PPE appropriately, maybe a little bit more appropriately going forward.
Yes, and I would definitely support that. I come from a primary care background, and that's exactly what primary care is. You see everything, and that only grows. You know, we are the first port of call for everything in the community, and so the level of exposure is very high. The level of exposure and risk to staff and patients is very high, but being such a fast-paced environment, it's very hard to coordinate training specific to scenarios in general practice, because you do see a lot of everything. So to answer the question that was asked, absolutely, Blue Mirror would be very useful for general practice for that exact reason. You've then got a tool that you can use when there is downtime or in between patients to have a practice session and keep that clinical skill up of donning and doffing safely and correctly. Can you record who has done the training using this tool? Yes, absolutely. For Blue Mirror, yes. So we've got options of how you identify staff or you don't identify staff, and it captures all the data on the sessions that have been run. So an example is organisations that use it and categorise departments. As a manager, I've got access to a dashboard, so I can see ED compared with this ward, compared with a ICU, and I can see how many sessions have been run, whether there've been corrective actions. And like connecting back to Mark's presentation, you know, having that transparency of your data is really important. So I can, rather than blanket approaching all the staff in my organisation, I can actually use my IPC resource to go to the area that needs more attention and know that everyone else is comfortable completing their training and not having so many corrective actions. So hopefully that's answered your question. I'm just going down here. And does Blue Mirror work without internet connectivity? Yes, absolutely. So that's one of the challenges that I'd mentioned before. It's very difficult in organisations where your internet can drop in and out, and we can work offline as well. So it's really important to have a tool that works all the time, and that's a key focus for us. I just want to go back to the presenters. If anyone else has anything to add, I'm just aware of time and I don't want to hold people up. So Mark, Ruth, Chris, did you guys have any other comments about today? Or otherwise I will feed through, if there's any unanswered questions, I'll feed them through to you guys after the session. But if you have any other comments, please go
Nothing
ahead.
from me, thanks, Holly.
Fantastic. Okay, cool. Thank you so much for your time. I really appreciate it. I loved listening and watching all your talks. It was fantastic. So really appreciate your time today. Thank you very much. I'll end the webinar for everyone now. Thanks, everyone. See you later. Bye.